So I have a talk about partial knee, but I'm not really sure I'm going to get into so much of it. I will have to say this. I spent, and I'm sure Amar has similar words, I spent my whole life trying to live up to my father's expectations. And I always knew it was impossible. And I tried so often to find chinks in the armor. I was, I guess, a very naughty kid. I always would be like, I'd always argue with my father. I'm like, no, you can't do this, you can't do that. And we'd be at meetings, and he'd be like, hey, Anil is such a debater, he's an arguer. And I'm like, well, you guys all think he's this mythic guy. He's just my dad, and I got to bring him down to the world. And I always tried to do that. I always tried to keep him just humble, whether we were playing tennis or he would watch a baseball game. In the first inning, he'd be like, oh, game over, Yankees lost. I'm like, Dad, it's the first inning. He would always just be so dogmatic and systematic, and I would always try to, I thought, make him more human. Now, all I could say is, although I am the renegade Ranawat, I do sports medicine, I do robots, and Amar has always been more of a disciple. I am 100% a disciple of my father and of his teaching and of his commitment to India. And over the last few years, as we finally see a few gray hairs on his head, I am more prouder today than I've ever been of my father. And I just want to tell you, Dad, I love you, and we all miss you. Now, Anand, give me 2 more minutes back on my timer. That's not, that doesn't count for my talk. You're giving me, come on, give me a little more time. Okay, so on that note, we got to go back to, I guess, orthopedics, because this is getting too lovey-dovey for any Ranawat party. So let's talk about current trends in partial knee replacement. I really believe, and we saw it yesterday with our debate with H2O versus uni, is that the uni market in India is dramatically going. When I gave this talk 10 years ago on robots and partial knees, everyone looked at me crazy. Last night, they had a partial knee debate. We had a second partial knee debate, and I heard, as of yesterday, 25% of the Indian market is now up to partial knees. So the world and the Asian market is changing. Because we know that total knee is a bigger operation. It's not always the answer. And unis have a lot of advantages, especially improved kinematics. It preserves the cruciates. It can be durable. And now we have fancier tools, fancier implants, fancier techniques to get them in. My dad would always say, no total knee can have normal kinematics that he's proved with Rich Comstock if you sacrifice the ACL. And the more we know from, on the ACL point of view, that a knee will not have normal kinematics if you take out the cruciates. Likewise, if you take out the cruciates, your function will be inferior. We know that both from multiple studies and also from sporting studies. So we know that the central pivot will normalize the knee. And a lot of implants have tried to reproduce the central pivot, the medial pivot knee, and other total knee designs, but they can't really do it. The only way you can keep the central pivot is by keeping the ACL and PCL. And this comes up to this concept of the forgotten knee score, right? If we were here in Hyderabad one year, my dad did Larry Dora's total hip, and we were at a temple for the gala party. 6 weeks post-op, Larry forgot he had his hip done and he just sat down. A total hip is a forgotten joint. A uni can be a forgotten joint. A total knee is a great operation for a big deformity, but it's much less likely to be a forgotten joint. But this is what I always hear whenever I'm at the table with Amar and my dad, that unis have a lot of problems, right? The failure rates are higher. It's much harder to do. The indications are tighter. There's problems with disease progression and compartmental overload. And the data is pretty clear. The Swedish registry shows a much higher failure rate. So this is why unis have always been pushed aside, especially in a market where you have a lot of price pressures, such as in Asia. We also know, like any procedure, but a uni is technically, I think, even more demanding than a total knee, that more volume makes you better. Well, that's pretty true, but I would say it's even harder for procedures like hip arthroscopy and partial knee replacement, where exposure is less. You can't just extend your exposure. It's harder to get because the cruciates are intact. And that's why with the advent of robotic surgery, what did it give us? Well, we want to get durability to up to total knee standards, right? Because the registry data is clear that it's inferior. And how can we get better? Well, we can get better alignment in the frontal and sagittal plane. We can helpfully eliminate the learning curve. And There are robots that's been shown to be successful in the heart and in the prostate, right? How many here people have colleagues in other surgical fields in India that are using robots, right? There are robots in India for other procedures, and there will be robots in India for orthopedics. So why do I love the robot? Well, it's highly accurate. It eliminates malalignment, which can eliminate early failure and edge loading, and it can truly eliminate the surgical learning curve. Now, it's not going to eliminate every problem. It's not going to eliminate bad indications, bad cement technique. You still have to be a surgeon, but it can really eliminate our fundamental main things that cause unis to fail. So, is the robot accurate? I would say yes. And there's multiple data points to show that the robot is superior to manual techniques in implant positioning. This is not just with a Mako robot, this is with any robot. This is with a hand. A robot will always be better than an average hand, even a master's hand. A robot will also be within 1 degree of component positioning. So the robot has been shown to be not more accurate in sizing, but also in alignment. It's also been shown to be better in soft tissue balancing with the soft tissue component of the robot. And lastly, it's been shown to eliminate the surgical learning curve. My first robotic uni looks just like my last one. The x-ray is highly reproducible. The time it took me to do the first one and the time it took me to the last one has changed a lot, but the x-ray has not. And that's really what we want to do. How do we get techniques, just like in our cars, that help us, right? Whether it's auto steering, auto braking, we're constantly making techniques, airbags, to make driving safer, except in an auto rickshaw. So, what is the robot? It's a surgeon interactive arm. You still control it. It's a CT-based program. There's no IM instrumentation, so there are other safety profiles that come with the robot. And it's a haptic force field. If I try to violate the posterior structures, if I tried to do a bad cut, the robot literally will turn off. It's very adaptable to someone like me who's an arthroscopist, because I look at a screen all day and recreate a 3D picture from a 2D picture. This is just one example of what it is. This is probably not a Ranawat incision. My dad would kill me if I showed that incision. I make a much bigger incision. You use a high-speed burr to sculpt the femur, and then you use the same high-speed burr to sculpt the tibia, and then you put your implants in. And it's very good for small deformity corrections. Again, I'm not saying this is going to eliminate a knee replacement, but it's going to certainly make it more accurate. Now, there are also robotic applications for full total knees, which we can talk about that later, but I'm focusing mostly on partial, where we have the most data. Robotic total knee has only been around for about 6 months. The indications, we've heard this a lot from yesterday. I think all of you know this. This is the Dick Scott indications that my dad was referencing before from the Knee Society. This is how you do it. You get a CAT scan to give you the full anatomy of the femur and the tibia, both rotational, and you can do your implant sizing before you get to the operating room. It's a CT-based protocol that's very low-dose radiation. And then intraoperatively, you do a real-time gap balancing. This operation is to restore the length of the MCL. So if you have a significantly contracted MCL, it's less ideal. As we've gotten better with the robot, I can now do an MCL release, something where you do a mobile bearing. You can't really do an MCL release where you don't want to do a lot of releases because you're worried about bearing spin out. With a fixed bearing, you can do a big valgus correction now. And then you get real-time gap balancing. I can adjust all the principles my dad laid out of balancing the flexion and extension gap. I can do that within a millimeter and move the femur up or down, the tibia up or down, depending if it's a balanced flexion gap or a non-balanced flexion gap. It's a very powerful tool, and it makes you re-understand all your total knee principles, but with a much higher degree of accuracy. Your post-op x-rays look like this. It's very reproducible. I reproduce constitutional varus, which we can talk about. What's your goal of alignment for a total knee? Total knee is slowly going to this constitutional varus. I think constitutional varus for a total knee is still a little silly because you don't have an ACL. But as long as you have an ACL and PCL, constitutional varus matters a lot to me, and I can match the patient's slope. So there are a lot of options, and now I'd add one more thing to the slide, which is a total knee, but you can do a patellofemoral as well as a bicom, and even add an ACL if you need it. The robotic data is coming out. It's better function than a total knee, has a lower complication rate early term than a total knee, and a lower revision rate, Mako, compared to a mobile bearing technology, as I mentioned there. So the interest is growing tremendously. In the last, say, 8 years since I've been doing this and since I've been talking about this, we've had Mako come here now for 3 or 4 years. It's growing tremendously. A big company has bought that. Our hospital went from 1 robot to about 5 robots. The cost effectiveness of partial knee now is becoming more and more efficacious, because right now when I do this operation, the patient goes home the same day. It's a same-day arthroplasty. And same-day total knee is coming to the United States too, but same-day partial knee is obviously, because of the metabolic insult, a much more easily acceptable circumstance. So we know partial knees are certainly underutilized. Asia's been showing that you guys are utilizing it more and more. I think eventually you'll hit your 25% and probably stay there, and we can talk about that. But I really believe that if cars are machined and implants are machined, the way we put our implants will be machined. And I see this 20% growth in our market in 8 years will be the future. So in conclusion, I think total knee is a great operation for large deformity. I think a partial knee is highly durable with modern techniques. Same-day arthroplasty is the future with proper pain control. There's cost savings with same-day arthroplasty. And just like I was talking to all of our friends last night, whatever happens on the other side of the big pond will eventually come to here, whether it's good stuff or bad, and the robot will be coming to you soon. Thank you very much.